Assalamualaikum and good evening, everyone. Thank you for finding your time and attending this CME organized by CME MedTweetMY Professional. I am Adila, your moderator for today. And our topic today is basic interpretation of cardiac stress test. And we are so lucky today that we have Dr. Faiz Mashood with us to share about the cardiac stress test. But before we begin, I would like to remind, if you have any question, you can write in the Q&A box, and we will address your questions toward the end of our session. And for this CME, you will get 1 CPD point, and we will give the link for the e-certificate and also CPD point in the chat box at the end of our session. And we will open the link only for 30 minutes. And without further ado, I would like to invite our speaker, Dr. Faiz bin Mashood, a registrar in cardiology and internal medicine from UMMC, to talk about basic interpretation of cardiac stress tests. Please welcome Dr. Faiz.
Okay. Hi and good day and good evening to everyone. My name is Faiz Mashood, currently working and practicing in UMMC. So yeah, beforehand, I would like to give my thanks to MedTweetMY for the opportunity and the invitation given. And I would like to give my thanks especially to the participants as well for the willingness to learn and spend your time, especially on a weekend night, to learn regarding this topic. So without further ado, I think we can start with our topic today, basic interpretation of a cardiac stress test. Okay. So we start our session with a case scenario. We have a 50-year-old lady with DM, hypertension, and dyslipidemia. She initially presented to our center with a typical angina for the past 2 months. Typical in the sense it was retrosternal and slightly heavy and associated with left-sided discomfort and mild SOB. Otherwise, it intermittently occurs, but it resolved on its own after 3 to 5 minutes. She didn't consume any NSAIDs or analgesics or GTN. So examinations were completely unremarkable and vital signs were normal. And ECG was done, sinus rhythm and no STT changes despite on serial ECG. And the HbA1c was 7.3%. I can say, acceptable. And echo was done, showed left ventricular ejection fraction of 68%, which is considerably normal. No regional wall motion abnormality, and valves were all completely normal. And biochemical marker like cardiac enzymes, CK and TROP-I were completely normal as well. So at this point in time, I know, majority of us may treat our lady here as a ACS, unstable angina, and admit the patient. And some of us might treat as stable angina and maybe discharge with a single antiplatelet and give either whatever diagnostic cardiac test such as EST or CTCA. So comes to our next question. What and which cardiac stress test is the best for our lady? All right. So is it an exercise stress test, or anyone want to go for a dobutamine stress echo, DSE? Or is it a CTCA, CT coronary artery, or MRI cardiac perfusion, or nuclear perfusion scan? Or maybe some of us might even want to jump straight into invasive coronary angiogram. Why not? It's a diagnostic and therapeutic as well. And maybe the patient is medically covered by insurance, right? So why not we just whack all of the above? At least we can come to the most accurate diagnosis of CAD and intervene afterwards. All right. So I want everyone to keep your own answer to yourself, and we'll get back to this slide by the end of the session. Most importantly about this slide is actually, these are all the available diagnostic cardiac tests worldwide, and this is as per what guideline has suggested. All right. So for us as a physician, as a doctor, to decide which is the best test for our patient, we need to know at least briefly on each of the tests and how to differentiate between each of the tests. So I will share a few options on how are we going to differentiate between each test. All right. So firstly, we differentiate each of the tests by knowing how each of the tests assess myocardial function. So based on ESC as well, we divide each of the tests either via anatomical assessment or functional assessment. All right. So what does it mean by anatomical assessment? So anatomical assessment means we look directly to the coronary arteries via contrast imaging. So for example, like in the case of a CTCA and even invasive coronary angiogram, we will push contrast and we can visualize the RCA, the LAD, and the left circumflex and the branches as well. And from there, we'll decide either is this just a mild plaque disease or is it a significant stenosis more than 50% up to 99%, all right? So from there, we'll decide either we need to intervene or we want a medical therapy or we want to revascularize via a balloon angioplasty and a PCI. So from here, we know the cardiac test that use anatomical assessment is CTCA and invasive coronary angiogram. Then what about functional assessment? So functional assessment, it means that each of the tests will provide stressor to the heart, all right? And from there, the hope is to induce a transient myocardial ischemia, which we can look at the result of each of the tests. So like, for example, I take AST. So the stressor for AST itself is the exercise on treadmill, right? Which will increase further our heart rate. So the result of myocardial ischemia, we can see via clinical symptoms of the patient, either they are complaining of angina or SOB. And we can see ECG changes, either ST elevation or ST depression or even U waves, right? Whereby for dobutamine stress echo, the stressor would be the pharmacoagent dobutamine itself. And how we look for myocardial ischemia changes for in DSE, we compare the ejection fraction and the regional wall motion abnormality and even the diastolic and systolic dysfunction before, during, and after the test. So from there, if there's any discrepancy in any of the parameters that I mentioned just now, that's a sign that patient might be having underlying CAD and we need to intervene as well. Whereas for MRI cardiac perfusion and nuclear perfusion scan, for MRI perfusion, the pharmacoagent will be adenosine. And again, for nuclear perfusion scan, we'll use dipyridamole as a pharmacoagent. And for both of the tests, the result, they will divide the heart into 16 segments. And they will report each of the segments, either is it viable or is it non-viable? Is the segment perfusible? Or is there any perfusion defect on any one of the segments? And let's say there's any perfusion defect for, let's say they mentioned the anterior segment got perfusion defect, and we can understand the anterior segment likely is supplied by LAD, for example. So we can presume that LAD is the culprit vessels, most likely having significant stenosis, and we might need to intervene later as well. All right. This is the first option on how to differentiate each of the tests, which is anatomical versus functional assessment. Okay. So secondly is to know at least briefly on ischemic cascade. So at least we know each of the tests where they located in the ischemia progression. So for example, local ischemia, all right, sorry. So we start with metabolic changes here, right? Then after local ischemia, there will be a perfusion changes. So perfusion changes can only be detected by our MPI, means myocardial perfusion imaging, which is either our cardiac MRI or our nuclear perfusion scan. So cardiac MRI and nuclear perfusion, they detect ischemia at this very early stage, all right? So that's why their specificity is considerably quite high. So after this perfusion changes, the ischemia will progress to cellular changes, which means there will be a myocardial necrosis, but at this point of time, still at cellular level. And subsequently, we will have diastolic and systolic dysfunction. And this can be evidenced and can be seen by echo or when we do a DSE, dobutamine stress echocardiogram. All right. And the ischemia further progress, only we can see ST changes on the ECG. So this is where our EST comes in, right? So like, for example, our EST, it's positive. The likelihood of our patient having CAD is high because why? We detect ischemia at almost at the end stage or at the late stage of ischemia cascade, provided we interpret the EST accurately. So after the ST changes, if the ischemia further progress, there will be a myocardial necrosis, but this time it's at the tissue level. So at this point in time, most of our patients, they will come to emergency with a complaint of again angina and the associated symptoms like maybe near syncope or SOB, and you can see ECG changes and also markedly raised troponin I as well. And at this point of time, usually we will admit to treat as ACS either unstable angina, non-STEMI and a STEMI. And sometimes patient may come with a very severe threatening, life-threatening ACS. They may come with a ventricular tachyarrhythmia and even sudden cardiac death. All right. So this is the second option, how to differentiate between tests. The first one is just now the anatomical versus functional assessment. And the third one, and I think one of the most important one as well, is the pre-test probability of likelihood of having CAD. All right, so remember this table. This is a PTP table from CPG of stable CAD 2018 from our CPG itself, which we adapted from ESC guidelines of 2013. All right, so we can see we got three zones here. We got three colored zones here. So again, this pre-test probability classify our patient based on age, based on gender, and based on the symptom itself. So the green colored zone is actually the low likelihood of having CAD. The likelihood is less than 15%. All right. So whereby for those that fall under the yellow colored zone, consider as an intermediate likelihood of having CAD, which means range between 15 to 85%. The range is quite broad for intermediate group, whereby for high PTP or high likelihood of having CAD is the red colored zone, more than 85%. So based on this, it will guide us what sort of test that we want to do next. For those that fall under the green colored zone or low PTP, we can consider non-cardiac causes first, rather than jump straight to the functional assessment or any form of cardiac stress test. All right, whereby for those that fall under intermediate PTP, intermediate group, we can always do any form of diagnostic cardiac test. Again, like I mentioned just now, it could be CTCA, which is anatomical, or it could be another functional assessment with DSE or cardiac MRI or nuclear perfusion. And for those that fall under this red colored zone, high risk group, and either we want to do a diagnostic test first, provided patient is asymptomatic, or let's say patient is symptomatic despite medical treatment and they are at high risk, we can always jump to invasive coronary angiogram because it's both diagnostic and therapeutic as well. All right. So next is another PTP table or PTP score of a likelihood of having CAD, but this is the most updated one from ESC guidelines 2019. All right, so I assume we can use this PTP rather than previous one. I just share both, just to mention that our CPG also got our PTP score as well. But this is the most updated one from ESC. And again, we divide based on gender, based on age, and based on symptoms. And from here, we can see three colored zones. The one gray colored zone, that one is considered very low risk of having CAD, less than 5%. Those that fall under the light green zone, this one, light green zone, right? They are considered low risk, 5 to 50% likelihood of having CAD, whereby those that fall under this dark green zone, they are considered intermediate risk group, more than 50% likelihood of having CAD. So again, so those that fall under very low risk, right, the gray colored zone, what is the best option? Again, the best option is for us to work out for non-cardiac cause again, rather than jumping to any cardiac diagnostic test to rule out CAD. Whereby for those that falls under the light green zone, we may consider to do an cardiac stress test after we assess clinical assessment and we assess based on a modifier which I will share later. And for those that falls under this dark green zone, which is intermediate risk of having CAD, we can always choose any form of diagnostic cardiac test in order to evaluate for CAD. All right. So this is one of the important table and one of the important slide for this topic as well. But it's in the ESC guidelines 2019 of management of CCS. And This is a diagnostic pathway for CAD based on ESC again. This is the modifier. So we can look at the table there. The one on the left can decrease the likelihood of our previous risk classification, and the one on the right is the factors can increase the likelihood of having CAD. So for example, we have an intermediate patient in an intermediate risk group. So but our patient have normal EST, for example, or they have a normal coronary CT and normal CT coronary calcium. So from intermediate risk group, we can consider our patient falls under low risk group instead, because they have one of these modifier. And another example would be, let's say we have an intermediate risk patient and they has any of the increased likelihood factors here, if either maybe they have their comorbids or their resting ECG already got the changes, and LV dysfunction evidenced by echo or abnormal EST again. So from intermediate group, we can consider the patient as high risk group. Okay, all right. So this is a modifier for the PTP score that we mentioned just now. So again, you can see what we can conclude from this table. EST acts as a bridging or as a filter which can influence our PTP score. So EST is considerably quite important still, all right? And again, this is from ESC in 2019. The more left you are, the more lower the risk of having CAD, and the more right you are, the more higher risk you are having CAD. So you can see here for the very low risk CAD, for those that falls under the gray colored zone, there's no need for diagnostic testing, all right? But if let's say our patient falls under low risk around here, there's a role of CTCA, provided local expertise and availability of resource. If let's say the patient falls around here, intermediate to high risk, testing for ischemia is mandated. Testing for ischemia is different from CTCA in the sense we are talking about functional assessment test here, which is again, like we mentioned just now, DSE, cardiac MRI, and nuclear perfusion imaging. And let's say the patient, falls under the high risk group at the most right here, we can jump straight away to invasive coronary angiogram. All right, another diagnostic pathway from ESC, like as per what we mentioned just now, low risk group and no history of CAD, we go for CTCA first, whereby high risk group, and provided we have the local expertise and the resource available center, we can do non-invasive testing for ischemia. This is the functional test that I mentioned just now, the DSE, CMR, and the nuclear perfusion. And let's say high risk group, but severe symptoms, refractory symptom, despite our medical therapy, yes, we can jump to invasive coronary angiogram. All right. So from invasive coronary angiogram, you guys see here, we divide it into three. Let's say the result of the coronary angiogram, maybe mild plaque disease. All right. So mild plaque disease or stenosis that does not need intervention. So we go for medical therapy here. So let's say the stenosis during angiogram is indeterminate or uncertain. We can always do a functional assessment during coronary angiogram, which we call it as FFR study or QFR study, I think the latest one. And whereby, let's say, if the stenosis is pretty much very significant, we have not much of a choice but to do a balloon angioplasty and a PCI, putting a stent in, either whatever it is, could be drug-eluting stent, drug-eluting balloon or whatnot, and revascularize the culprit vessels. Okay. All right. So this is the evidence of diagnostic imaging tests based on ESC again. So I would like to highlight and emphasize to everyone, because we practice evidence-based medicine, right? So I just want to recap to everyone that you can see here class 1, class 2A, and class 3, right? So class 1 evidence means it's highly recommended, all right? It's highly recommended to practice. Class 2A means it should be considered. It should be considered. We got in between actually class 2B. Class 2B evidence we may consider to practice, but anything that falls under class 3, advisably not to practice. All right. So we focus on the class 1 evidence for our cardiac stress test. So the first one we can see here, functional imaging is recommended as CTCA or imaging test is recommended to diagnose CAD if we are unable to ascertain whether patient having CAD or not based on clinical assessment. It's a class 1 evidence. All right. So, and the second one, non-invasive diagnostic test is done based on the clinical likelihood of CAD. So this, we are actually talking about the PTP score just now. So applying the PTP score, the table just now, to our patient is a class 1 evidence. So it's very important to acknowledge the existence of such score. All right. And then the functional imaging for myocardial ischemia, for example, again, cardiac MRI, nuclear perfusion, and DSE is recommended as class 1 evidence if, let's say, CTCA is uncertain. And another thing, the class 1 for invasive coronary angiogram, if, let's say, patient falls under high risk group and the symptoms is pretty much severe despite medical therapy, yes, we can go straight to invasive coronary angiogram. And the rest of the evidence, I mean, you guys can always read this in the ESC guidelines in their website. All right. So fourthly, on how to differentiate between each test. Okay, before we focus on EST, I just explain on each of the tests briefly, so at least we understand what's about all the tests and what's the choice that we have other than EST lah. All right. So this table again is from our CPG of 2018, CPG of stable CAD. So we can see here, all right. EST, the specificity is 85 to 90+%, which is considerably quite high, but the sensitivity is about 50%. So what does this mean? So specificity high means, let's say the EST is positive, right? The EST positive. So the likelihood of having CAD is high, okay? And if you guys remember the ischemic cascade just now, EST always detect the ischemia at the end stage. So that's why it's very specific. But the sensitivity is low, which means, let's say our EST is inconclusive or negative. It does not almost exclude CAD. Right? It does not almost always exclude CAD. So let's say our patients, we have EST inconclusive or maybe negative, but persistently having symptoms. And the cardiovascular risk score based on Framingham score is considerably high. You can almost always think to do another imaging test. Okay. So this is for EST. Then for DSE, again, the specificity is more or less the same, but more sensitive compared to EST. And for nuclear perfusion and MRI perfusion, you can see the specificity ranging from 60 to 85%, and the sensitivity is also considerably quite high. All right, and cardiac MRI again and nuclear perfusion, they detect ischemia at the very early stage. All right. Remember the ischemic cascade just now. Okay, and CTCA is very good to rule out CAD. The sensitivity is almost 100%. So if, let's say, CTCA report as no normal coronary arteries or very mild plaque disease, so it almost always conclusive. Okay, so this is another diagram or figure from ESC, again on sensitivity and specificity of each of the diagnostic cardiac tests. It's more updated because it's released in 2019. I just would like to highlight on the upper left corner here. You see EST, right? The green colored here is the likelihood of the ability of the test to rule out CAD, and this one is the ability of the test to rule in CAD. So compared to our CPG in 2018 and this ESC in 2019, we can see the sensitivity and specificity of EST is getting lower and lower actually, right? So yeah, it's getting lower and lower. So now the question comes in. So why do we need EST, right? Why can't we just abolish EST from our diagnostic cardiac test? Because we have many other imagings that is more sensitive and specific, right? I understand that concern, but okay. So we go to the next slide now. Why EST? So firstly, it's widely available, easily accessible. So, and it can be interpreted by non-cardiologists, a well-trained physician, and even a well-trained medical doctor from private or from government. They can interpret EST and they can give an accurate test, accurate result. All right. Second would be cheaper cost. CT scan and MRI and nuclear perfusion, it can cost you thousands, all right? So especially in the private setting. And no radiation and no intravenous access needed for EST. And again, EST is just not to look for evaluation of CAD. There's more other function of EST. For example, we can assess our exercise functional capacity to predict our prognosis survival of 5-year survival rate. And then alternative to diagnose EST act as an alternative to diagnose CAD if imaging tests are not available. But need to keep in mind the possibility of false negative and false positive result of EST. Okay, now we focus on EST alone. Okay. All right. So what are the contraindications for EST? So you can read the table here. It's quite lengthy. There are absolute and relative contraindications. But I just want to make this very clear and very easy, right? So anything got to do actively with the heart, okay? Anything active ongoing to the heart, acute endocarditis, acute pericarditis, acute myocarditis, acute heart failure, then what? Acute coronary syndrome, completely total absolute contraindications to do EST, all right? There's no way you're going to do EST in such patients, all right? And for relative contraindication, you guys can see here, left bundle branch block, all right? So left bundle branch block is almost always ischemic in nature. Most of the cause of LBBB is almost always ischemic. So that is why most of our cardiologists or physicians avoid EST and in LBBB patients because we have more other alternative. All right. So for HOCM also, it's not advisable because they can have syncope during EST. And again, for those with resting blood pressure, even before starting the test, systolic more than 200 and diastolic more than 110, advisably not to proceed because we expect the blood pressure to increase slightly during EST, and we don't want to put our patient to such dangerous event. All right. So I think this picture summarizes everything about EST. We have our patients there, all right, and we have our blood pressure cuff monitoring and vital sign monitoring. We have our chest ECG chest rate attached on the chest of our patients. We have the monitor there to trace the ECG, and we have our handsome physician or cardiologist or non-cardiologist here to interpret the EST and ready to refer to a nearby cardiologist. All right. So, all right. For EST, we use Bruce protocol. In certain events, we use modified Bruce protocol for a post-cardiac revascularization patient. So what is Bruce protocol? So Bruce protocol, mainly we divide into 7 stages, all right? And each stage is 3 minutes, all right? And with increasing stage, there will be an increase in speed and increase in gradient or the slope of the treadmill. Okay, so we can see METs here. METs is metabolic equivalent. I'll get to this in a while. Basically, the higher our METs, the better our outcome, our survival or prognosis is. All right. So what is METs? It's the rate of energy expended per unit time, or we can say intensity of an exercise or activity. So the higher our METs is, the more intense exercise we can compensate, which means it's a good thing, right? So for METs, anything less than 8 is considered, anything less than 5 is poor, 5 to 8 is considered fair, 9 and above is good, METs more than 12 is considerably excellent. So we can conclude here, anyone who passed stage 2, who entered stage 3, the METs is already acceptable, right? So inability to exercise more than 6 minutes or indirectly inability to pass stage 2 or inability to achieve target heart rate, I'll explain on target heart rate later, is a significant indicator that the risk of CV event in 5 years is ranging from 50 to 70%, which is high, all right? And however, for patients, independent of CAD or not having CAD, if they're able to achieve METs more than 10, their 5-year survival rate is 95%, okay? So this is the formula of target heart rate. Maximum heart rate, predicted heart rate is 220 minus age. And whereby target heart rate will be 85% from our maximum predicted heart rate. So for example, my age, right? Maybe 20 years old, very young. 220 minus 20 is 200. That's a maximum predicted heart rate. but target heart rate will be 85% times 200, which is I think 170. All right. So for me to do EST, I must achieve the target heart rate of 170. Then only we can discuss about the result. Then only we can say the result is conclusive. Any of our patients who do EST but does not achieve target heart rate, the result is considered inconclusive. Despite they able to complete the test, despite there's no symptom, despite ECG got no changes, if they are unable to achieve target heart rate, we can't say the result is conclusive. So important to achieve target heart rate during EST. And again, we have a Duke treadmill score, which we calculate. This is the score to, how to say, to predict the risk of having stenosis more than 75%, multivessel disease, and 1-year mortality. So the exercise duration here, let's say able to exercise for 10 minutes minus 5 times ST deviation in mm. So one small box is 1 mm. So let's say got ST deviation, we put there as a score. And minus 4 times angina index. So angina index, we got a score 0, 1, and 2. All right. So 0, this depends on the either the patient having angina or not. And then we calculate the score. And from there, we decide either the patient falls under low, intermediate, and high risk group. And you can see high risk group here, the stenosis of more than 75%, prediction is 99%. It's very, very high. Multivessel disease also 93%. And 1-year mortality is 5.2%. Okay, all right. So when to terminate EST? Okay, again, when to terminate, I want to make this very, very clear and very, very easy for everyone. We make it very logical. So the moment patient, let's say patient raise hand and say, doctor, I want to stop. I don't want to proceed. Just stop the test. Don't ask so many questions. Why you want to stop? Keep doing it, whatever, because I mean, the patient want to stop, there must be certain reason, and we always have an alternative test. Don't push the patient to complete the test. And the moment patient complain of any alarming symptom, chest pain, SOB, or palpitation, or near syncope, or even syncope itself, so yes, please stop the test. And the moment you see any drop in blood pressure, systolic more than 10, right? More than 10 drop, it's a marker that you need to stop. Ideally, it shouldn't be dropping. It should be increasing instead. And any new development of bundle branch block, new bundle branch block during EST, please stop the test. It's almost always ischemic in nature. All right, and you can read other indication to terminate EST. This one, I mean, maybe you can see from the recording, or you can even Google up this. Okay. So I think this is one of the most important slide as well. What is a positive EST? We got three criteria here. ST elevation more than 1 mm. 1 mm is one small box. So any estimation more than 1 mm, whatever lead, either chest lead or limb lead, yes, stop the test. It's a positive EST. Please send patient for revascularization, or if let's say you are in doubt or whatever, please proceed with another imaging test such as DSE, cardiac MRI, and nuclear perfusion. Okay, because you need to understand that ST elevation in EST, 15 to 30% can be Prince metal angina. All right, but how we want to confirm that it's a Prince metal angina? So better to overestimate rather than underestimate. So okay, that is for ST elevation. I think everyone is clear. ST elevation is almost is positive test. U wave inversion. So U wave inversion, we are talking about new U wave inversion during EST, not a resting U wave inversion. The resting ECG of U wave, that one could be due to electrolyte abnormalities. I think everyone acknowledge this. We are talking about U wave during EST. There's a study here which was published in AHA journal. You can see exercise-induced U-wave inversion is a marker of stenosis of LAD. So from this study, from 248 patients, 36 patients, which is 15%, developed U-wave. And from that 36, 35 had more than 75% stenosis. So it's more than 95%. We know in one of the major coronary arteries. So U-wave is positive for EST. I mean, talking about new U-wave that developed during EST. And now we go to the ST depression. I think this is the most misinterpreted part of EST, the ST depression. So before we proceed, we need to understand ST depression. We got 3 types of ST depression. Either it's a horizontal ST depression, right? Or down-sloping ST depression, or up-sloping ST depression. Okay, we go on to the next slide. So, all right, ST elevation is not an issue. U wave inversion also not an issue. So now we are talking about a down-sloping ST segment depression. This one, down-sloping. All right, and this is up-sloping. Okay, so we talk about which is the significant type of ST depression for EST. Okay, okay. So, okay. There's a difference between there's difference between upsloping ST depression like this one and J point only depression, and how to differentiate that. Okay, we go to the next slide. I think this is a more easily understand figure here. So first of all, we need to know where's the J point. Where's the J point? So J point is the intersection between S wave and the start of the ST segment. So this is ST segment, right? ST segment. This is our S wave. The intersection is the J point. Okay. So this J point, in order for us to know either is it a true ST depression or not, we need to go 80 milliseconds from J point here. So what is defined as 80 milliseconds? It's a 2 small box. All right, 2 small box is 80 milliseconds. So 2 small box from J point, then only we read from here. We are not going to read ST depression here. We're not going to read ST depression here. We are going to read here, which means 2 small box after J point. So then, after we have our 80 milliseconds from J point, you can see here. Okay, in order to say it's a ST segment depression, at least 1 small box. Okay, so for example, like this one, J point depression, maybe the J point is here, then 80 milliseconds is here. So we compare what's the distance between this 80 milliseconds from J point to the isoelectric lines. If it's less than 1 small box or less than 1 mm, it's not an ST, it's not a ST depression. It's just a J point depression, which is a negative ECG response. Okay, which could be a normal thing. So let's say our patient is here. This is J point, 80 milliseconds is about here. Then what's the distance from isoelectric line? If let's say it's more than 1 small box, at least 1 small box or at least 1 mm, it is considered as upsloping ST depression. But 1 small box only is considered equivocal. All right, equivocal. Okay, in order for upsloping ST segment depression to be considered as a positive EST, it must be 2 mm or 2 small box. This is only for upsloping ST depression, right? 2 small box, upsloping STD, it's a positive. Only then we say it's positive EST. For horizontal, I don't think we have much issue. ST depression, the whole ST segment horizontally is depressed, and when we compare with the isoelectric lines, at least 1 small box, yes, it's a positive. It's a positive ST. And I think for downsloping ST depression also, we don't have much issue. J point is here, maybe 80 milliseconds around here. More than 1 small box, at least from the isoelectric lines, is considered positive enough. 1 small box is for horizontal STD and downsloping STD. For upsloping STD, we need 2 small box to say it's a positive EST. I hope, I hope the participant can understand this. Okay. Okay. Yeah. So back to this slide. Yeah, ST depression more than at least 2 mm upsloping is positive. At least 1 mm horizontal and downsloping is positive. The rest for ST elevation, U wave inversion, I think everyone is clear on that. All right. So next is anything other than those 3 that I mentioned just now is inconclusive or equivocal EST. Any ECG changes other than those 3 is considered inconclusive. So if we still highly suspicious of our patient having CAD, we have no choice but to consider another diagnostic cardiac test. Okay. All right. So evidence of EST based on our ESC guideline. So the only class 1 evidence is this one. EST is recommended on top of evaluation of CAD for assessment of exercise tolerance, to assess symptoms, to check for arrhythmia. Certain arrhythmia can be unmasked during EST, to check for BP response, and to evaluate event risk in selected patients. All right, so I'd like to emphasize again and again, EST, we can treat or can consider it as a bridging to our next non-invasive imaging test. Okay. So, okay, I think we are almost finishing here. So, okay, I mean, it mentioned here equivocal EST. EST is only equivocal to all of the tests I put here, cardiac MRI, DSE, CTCA, and nuclear perfusion, if and only if all these tests are not available in our center. If, let's say, the tests are available in our center or in a nearby center, EST is inferior to all this. All right. That's why in the evidence from ESC, they rarely mention about EST actually. They mainly mention about CTCA and the functional test, which the functional test again, DSE, cardiac MRI, and nuclear perfusion. So this is just an image for coronary angiogram. As well, what I mentioned just now, coronary angiogram is anatomical assessment. So we can see a nice view of RCA here and its branches, and left circumflex and LAD. Okay, so coronary angiogram is an anatomical assessment, but we can do functional assessment as well during angiogram, which we call FFR or QFR study. All right, that one I may need to read into detail later. Okay. So this again from our ESC, this is not, a definition of positive test. This is a definition of a high event cardiovascular risk for each of the tests. So, you can read here for EST, let's say the Duke treadmill score more than 3%, the high risk to develop CV event is high. For nuclear imaging, ischemia, at least 10% is considered high risk. For DSE, at least 3 out of 16 segment, which has a stress-induced hypokinesia or akinesia, is considered high-risk event. For cardiac MRI, at least 2 out of 60 segment, which shows perfusion defect, is considered high risk. And for CTCA or invasive coronary angiogram, 3-vessel disease or left main disease or proximal anterior descending artery disease is a high-risk event. And this is a functional test that I say that we can do during angiogram FFR or IWFR. And I think the newest one is QFR, if I'm not mistaken. All right. So take home message from this topic. All right. EST is considered as an alternative test to rule in and rule out CAD. All right. And we need to understand if our patient falls under the very low risk likelihood of having CAD, doing EST can bring a false positive test. That's why I said we need to exclude first non-cardiac cause before jumping to all these cardiac stress tests. And CTCA is a preferred test for low likelihood of having CAD group and for those who has no previous CAD. And ultimately, again, our selection of choice, our selection of tests, it depends multifactorial, again, on our patient's background and on our local expertise and the resource availability on our center. And before I finish our slide, again, I would like to remind my question on the first slide just now. We have our 60-year-old lady, and I asked what is the best cardiac stress test for our lady there. So if you listen to the lecture from the beginning until the end, you will know there's no one definite answer. We need to take further history instead. We need to ask the auntie or the lady, auntie, can you actually exercise? Can you jog? Then suddenly auntie said, I got bilateral knee OA. Then we can exclude EST from there. And then we need to know what's the local expertise and the resource availability in the nearby to his house. All right. Otherwise, I think that's that. With that, thank you very much. And I pass my baton to my colleague and senior and friend, Dr. Iskandar Mirza and Dr. Adila. All right.
Okay, thank you very much, Faiza. It's a quite excellent talk. Actually, if you want to know, all of you want to know, actually, I found Faiz in Facebook, actually. He like to do teaching in Facebook. So remind me during my medical officer time, So that's why actually this I invite him to become one of my members in MedTweetMy. And also I think this is the first time that he's giving talk under MedTweetMy. So it's very good talk about stress test. It's very important and easily accessible to every district hospital. However, we need to make sure that why we need to do. That's the most important part, because it's cheap. And also, even the sensitivity is 40 to 50%, but once it's positive, it's quite high. The positivity is very high. Okay, Faiz, we have a lot of questions. Actually, we try to go one by one. Okay, the first one from Arif. Why aortic stenosis is only contraindicated for EST? Bro, your sound.
Sorry. Okay. So I think we got a lot of questions here, and some of it maybe Dr. Iskandar can help me to answer as well. Dr. Iskandar is our fellow cardiologist from IJN. All right. So why aortic stenosis is contraindicated? So aortic stenosis, I mean, one of the most prominent symptom of the patient, and usually the patient is elderly, unless they got some underlying cardiac abnormalities. One of the symptoms is syncope. All right. So one of the symptoms will be, and we don't want our patient to get near syncope or syncope during the event. Sometimes even before the EST, even at rest, the patient already have this near syncope symptoms. So best to avoid, again, like I say, because we have, various alternative tests. EST is not the only thing, lah. All right. Okay. I think that's that for the first question.
Yeah. So it's correct. So you just imagine that the valve is very stenosed and there's a very limited flow to the heart. So when you stress the heart, actually the flow become lesser and lesser. So actually patient can just collapse. So we don't want to do. Okay, that's why it's very contraindicated. Okay. Okay, now we go to the second questions. Can patient with RBBB or ST depression do EST?
Okay. Okay. RBBB is not an absolute contraindication, and I don't think it's a relative contraindication as well. The relative contraindication is just LBBB. But why most of our physicians and cardiologists they don't like to put those who with baseline RBBB towards EST, because the end result, the ECG, the ECG changes during or even at recovery is not easily interpretable because of the RBBB itself. All right. And for ST depression, I think it's quite clear. I mean, it could be various causes, but one of it could be ischemic in nature. So best for us to avoid anything got to do with ischemia, better to avoid. All right.
Yeah. So RBBB, we don't like to use EST because it's going to be difficult to interpret the ECG. You want to see the ST changes everything, so better just do use the other modalities. We have a lot of other modalities we can access. Okay, next question. Can patient with white coat hypertension do EST? BP always normal at home, but during EST appointment, they BP more than 160/90.
All right. Okay. I mean, Dr. Iskandar, if let's say I'm wrong, you can always correct me. So BP more than 160/90, if the BP itself is 160/90, it's not a contraindication to the EST actually. The one mentioned just now, I think more than 200, and especially hypertensive urgency with some sort of symptoms. So either we stabilize the BP first, or we ask the patient to take his or her medication and come back later. But 160/90 itself is not, I mean, we can still proceed with EST.
Yeah, you are correct. Yeah. Okay, next one is what is the cost effectiveness of EST as compared of CT calcium scoring?
The cost effectiveness means the cost of each test. Is it? I can't really understand. Of course,
I think
EST is
the question is maybe which one is the better test? If we do EST is not conclusive, then it still need to do CT calcium scoring. So I think this is the question. But to answer this question, actually, of course, if cost effectiveness, actually CT scoring is much more better. However, it's not readily accessible. As you in the district hospital, you are sharing with other department to do CT also. Sometimes one need to do urgent CT brain, CT spine. There's a lot of things that you need to do, CT abdomen. So because of that, actually, that's why EST is the first preferred method, at least, especially for those in district. If the patient is fit to do test. Okay. Okay, so next, Salam and hi. I want to ask, can we do CTCA in ESRF patient? Secondly, how to interpret CTCA? What value we consider positive?
Okay, all right. What value you consider positive? Okay, hi. In those with the how to say CKD or advanced CKD, advisable to avoid not only CTCA, any contrast-induced imaging, advisable to avoid because the risk of CIN is there, contrast-induced nephropathy. All right. So CTCA usually is not an urgent procedure, so we can consider an alternative, maybe like nuclear perfusion imaging. Right. So, but let's say in ASRF patients, patient already on dialysis and already got no urine and anyhow has regular dialysis, again, we try to avoid because we usually, for those procedure that at risk of CIN, we need to do how to say, few consecutive days of dialysis in order to wash out the contrast, and which we can't do that as outpatient for CTCA because CTCA is most of the time is outpatient. So better to get an alternative test.
Okay, so yeah, Dr. Faiz is right because we have other modalities as technetium scan where the contrast doesn't really affect the kidney. So better you use that to assess the ischemia. And then how to interpret CTCA, what value that we consider? Actually, 0 is negative, 0 to 100 is intermediate, more than 100 is positive. So that's the value of calcium score. But there's another thing about this CTCA, if you use for those who have renal disease, kidney disease, or age more than 65, most of them already have calcified vessel. That's another thing that we have to consider. If this patient you think that have a calcified vessel, sometimes the result will be very severe stenosis or high calcium Agatston score is very high, more than 100. But when we do angiogram, actually, sometimes it's not even significant. It's maybe mild to moderate, not even moderate to severe. So if you think that the patient have this tendency to have high calcium score, actually, but patient is asymptomatic, you can do other modalities. You can do dobutamine stress echo, also is very good. There's sensitivity and specificity become increased when you do extra echo for the stress test, or you can do a technetium scan. There's another option that you can do in this kind of patient. Okay. Next one is it better to allow patient to reach stage 5 even if achieve maximum heart rate at stage 3 without any abnormalities?
Okay, good question there. It depends on what we want to assess on EST. So we have a different objective on subjecting patient to EST. If let's say the reason is to evaluate for CAD, so and those patients maybe some sort of elderly, the moment achieve target heart rate and we can see there's no ECG abnormalities and there's no symptom, we can consider to terminate. But if let's say we want to assess an exercise functional capacity, like example just now to calculate a due treadmill score and stuff, that one we will continue as long as patient is able to in order for us to prognosticate the patient. All right. I mean, Dr. Iskandar, is there anything to add?
Oh yeah. So actually, I agree with you, Dr. Faiz. Okay, so actually, most of us actually just want to know whether patient have evidence of ischemia. So enough by reaching the 85% of the target heart rate is enough. You already reached that, doesn't matter is stage 2 or stage 3 or you have to wait until stage 5. So you reach that target 85% is enough to know whether patient have ST changes also, just like what Dr. Faiz just said. Okay, but if you think that you just want to know how far the patient can go, like you want to assess athlete or other types of assessment, then that one you can just go how far you want. But usually we don't go. We just enough by knowing that we already reached the 85% of the target heart rate is enough. So because we already see the changes from the ECG from there. Okay. So next one is when do we choose to do dobutamine stress test?
Okay, maybe I let Iskandar answer this question because I think this modality is widely used in the in IJN, right?
Okay, so like this. So mostly when we use the dobutamine stress test is still a stress test, but when you think that the patient can't move, okay, can't walk, okay, you think that all people with bilateral knee osteoarthritis, so then you subject them for dobutamine stress echo because they just need to lie down. or the patient have some problem in standing or anything, you can just do that for determine stress echo, stress test. Or another one that we can do, actually, we can do this determine stress echo for those who want to assess diastolic dysfunction. But this is too deep for you guys. You just need to know stress test. Now we're only talking about stress test. So mostly determine stress test, we subject for those who can't walk or run during this at the treadmill. Okay, that's much more simpler definition. But of course, as I told you, stress test plus echo, or the determine stress test plus echo, the specificity and also severity become much higher, more than 80%. So I know that district center of course can't offer this, but it's only using in cardiac center, because the one who did the echo is a what we call this is a specific cardiovascular technologist, or the cardiologist, the one who did it during the stress echo itself. So if you have the determine stress test is enough already, or stress test is enough. If you have any problems, just refer. That's another way that usually how I look into it. Okay. So next one, is it recommended to do exercise stress test for healthy adult as a preventive measurement?
Okay, so preventive measurement, that one need to, clarify further. You mean prevention of cardiovascular disease, or I don't know. So, but if you're talking about preventive measure alone, there's much more alternative that we can do other than EST. Again, I need to remind everyone that those that fall under very low risk likelihood of having CAD from the PTP table there, doing EST can lead to a false positive result, which may bring a headache to many of us. So if there's no indication, better not to. If the question is just to know to prevent cardiovascular risk, we can always calculate our Framingham score or cardiovascular risk score, and we assess from there. All right.
Okay. So another way is, if you think that you want to do a medical checkup, you can do that. You can do that medical checkup for those who age more than 40 years old. You can do that. Most cardiac center offer that stress test, because usually you need a cardio trainee or cardiology team to actually subject you to what to do next after you do the stress test. So for healthy people, we don't say healthy lah. Mostly people who come to us actually is not healthy. They know that they have some problems. That's why they need to do the assessment. So sometimes actually, if you come for the medical checkup, usually we routinely do it so that actually we just want to know that if it is negative, then you can just repeat it after 2 or 3 years. Depends on your age and also your comorbidities. Okay, next one is, if patient is elderly, age more than 65, without contraindication for EST, do you prefer EST or modality or DSE? I think we already answered that question. So it's either patient can walk or not. If patient can walk, you just do EST. There's no question about it. As long as we can achieve the target heart rate more than 85%. But for debutamine, if patient cannot walk, then you subject patient on debutamine stress test. Okay. Next one, Faiz, is how to know whether PVC induced on EST need to be addressed or neglect, or not neglect lah, address.
Okay. I think PVC has its own, it's another whole topic actually. So the moment patient develop PVC, PVC can be benign, can be malignant. We need to know what's the underlying cause of the PVC. Hence, we need to investigate a blood test, might need to do a Holter to see whether it's a significant PVC or not, and echo and stuff to do, is it ischemic related or something else got to do with the PVC. So again, the question, yes, it needs to be addressed, but we need to know what's the underlying cause first, because not all PVC need treatment, unless, yes, that's kind of, anything?
So, no, sometimes when you notice PVC only happen during the stress test, sometimes you worry about ischemia. Ischemia also can cause PVC, and some patients just born with abnormal tract of the heart. So we need to address, we cannot neglect this. When you see a PVC, you can refer. First, if you don't see any PVC before the stress, then is probably something that induced the PVC during the stress. Mostly maybe ischemia, so more reason to refer cardio. But if you already see the PVC before starting the stress test, what I can suggest that first we need to calculate the PVC burden first. if and whether the patient is symptomatic or not. But regardless, both situations need to be referred to the cardiology, because actually there's a two pathway. One is through interventional team where they need to assess the vessel for ischemia. The one is through electrophysiological team where they can actually ablate the PVC. That can cause the longer that you have the PVC, the higher risk for heart failure. So that's why we need to address the PVC. Okay, next one. How soon can a subject patient who just had PCI to go EST? This one I answer for you. So actually, mostly actually when you have PCI, you will have cardiac injury. That's why for the first 2 weeks, we don't allow patient to do any exercise or anything. So if you want to do, you can do it maybe after 1 month, but actually still you need to justify why you want to do the EST, why you want to do, whether the patient that you think that having chest pain, then you, by that you have to think of instant restenosis. For that, actually you don't need to do any stress test. You just subject the patient to go for angiogram straight away because we need to address that matters. So if you ask me, actually the safest one is more than 1 month. But if patient have symptoms, usually we don't wait. We straight away go for angiogram straight away. Okay. Okay, next question, Faiz. What about T inversion? Well, our question is more and more. Every time I take up one question, then suddenly still a lot. Okay, what about T inversion in stress test?
Okay, we need to put an end to this. Okay. So, okay, T-wave inversion, as just per what mentioned at the sides. Okay, other than those three, the ST elevation, ST depression, and U-wave, T-wave inversion, we can consider that as a PVC. I mean, it can be various causes. One of it could be ischemia, and could be other things as well. So again, need to investigate, need to evaluate with other blood tests and other imaging cardiac tests to check whether is it really true ischemic in nature or is it something else.
Okay. So next question from my previous houseman, Nabila. When test is terminated due to patient having cyanosis, request to stop or other causes, is it considered as inconclusive?
Yes, inconclusive.
So it still depend on the ECG, what you can see. It can be due to lung problem, it can be due to heart problem. So if need to stop, just like Dr. Faiz say, you stop, just stop. But you have other types of modalities, don't worry. Okay, but if a patient has cyanosis, a bit worried about the lung also. So that's why both assessment of the lung and heart is very important for this kind of situation. Okay. Let me choose another one question for you. Okay. Okay, last question from Arifa. Is there a rule of repeating EST in post-PCI CABG?
Okay, there's a role. So after PCI or after revascularization, ideally, the myocardium will remain viable, and all the plaque or all the stenosis, the blood flow, all will be, how to say, revascularized and completely reserved. So by right, they shouldn't have any issue doing it, and the result should be it can be either better from even before PCI, because we have revascularized the heart. Yeah.
Okay, yeah, actually I agree with Dr. Faiz. We can do PCI, but if you think the patient post CABG, I would prefer the CT scan, CTCA, because why? Because we want to assess the graph. Patient can have 1 graph, can have 2 graph or 3 graph. So from there, we can assess properly which graph is occluded, and it's quite good if we do a CT scan for the patient with the post CABG, that if you think that the patient have ischemic pain. Okay. I think that's it for today. Thank you very much, Dr. Faiz. I give the floor back to Dr. Adila.
Thank you, Dr. Iskandar and Dr. Faiz. Actually, we have a lot of active participants today and a lot of questions, but we are sorry that we cannot address all your questions because of the limited time today. But on behalf of everyone, I would like to thank our speaker, Dr. Faiz, Dr. Iskandar, and everyone who participate in today's CME. And now we have come to the end of our CME session, and we sincerely appreciate your participation today. Thank you for spending your evening with us, and see you on next CME. For the link of the e-certificate and CPD point, we already put in the chat box, and we will open the link for 30 minutes only. Okay.
Okay.
Thank you, everyone.